Eyes on Dry Eye 2023. I am Dr. Damon Dierker coming to you live from Indianapolis. Very excited about this session tonight, the state of dry eye in 2023. We have so much to talk about. Let me introduce my esteemed co-panelists. And first of all, my co-host, Ahmad Fahmy. This is our fourth huge virtual program, thousands of people on from all over the world. Excited to have you here tonight with us. I'd like to introduce Dr. Periman from the Great Pacific Northwest, Seattle, the dry eye master. And last but not least, Maharaj from Ontario, leader of the Canadian Dry Eye Summit, some of the greatest dry eye minds in the country and the world here. It's a really exciting session. So the state of dry eye, we're going to talk about new innovations in our clinic that we're doing now, how our treatment algorithms have evolved over the last couple of years, and then a look ahead at 2023. We have up to maybe 4 new medications in the US that could be approved for ocular surface disease. Very exciting time for our patients. Let's get started here. So new innovations. Ahmad, why don't you lead us off on point of care diagnostics?
Awesome. I mean, I think, thank you again, Damon, for such an awesome introduction, and I'm really honored to be here with you guys. Super excited about this, just kind of being able to pick your brain about all these things. I mean, one of the things that we've really been sort of spoiled in dry eye disease and ocular surface disease is point of care tests. Of course, osmolarity has been such a pivotal role in helping us understand how to treat our patients and then monitor those patients. And I want to kind of talk to you guys about how sort of, kind of specific we're getting at this time in our kind of current treatment algorithm. And there's with the tear film, one of the things that we've talked about so much is how important that diversity is, and how we're kind of looking at things like lactoferrin and IgE. And what excites you guys about specifically lactoferrin? I think of it, there's so many important molecules on that tear film. What's the buzz about lactoferrin, and why is that such a pivotal thing to be looking at?
I'll start off with that one. I think lactoferrin has been well demonstrated to be a unique biomarker around the health of the lacrimal gland. And so when you see significant changes in the level of lactoferrin, that tells you the lacrimal gland is under distress, and you need to be more aggressive in treating inflammation and hopefully help reverse some of that damage inside the lacrimal gland itself and prevent further damage. Get more aggressive with your inflammation control.
Yeah. Awesome. And so do you guys are you at a point where you feel like, okay, I want to be able to walk into my clinic, my sort of treating my patients, and know that this patient has this enzyme that is lacking in their tear film. Here's how I want to treat it. Are we getting really kind of into the woods, or too deep into the woods, too complicated into this? Or is it super helpful for you to get down to that level where we're looking at these specific biomarkers?
I'll jump in. I think it's a really valid point. I think we are at a precipice, and Laura, I think you'd probably agree, we are at a precipice where, the innovations that are going to be coming out this year and for the next, 5-10 years are going to become far more specific. So I think that while we don't have a lactoferrin specific agent at this point, I think it certainly sets the stage for us to look at the disease with a closer lens, still being able to zoom out, but also really kind of looking at a closer lens, because as these options become available, and to be able to target therapy towards it, I think that's going to become increasingly important as we go forward.
I agree. And if you look back historically, back in the day when we were looking at glaucoma, all we had were visual fields and disc fundus photographs, like old school Kodachrome, all the whole thing. And look how far we've come. And yet we dovetail in these other modalities looking for early signs of damage with ease and precision. So with that model in mind, as we gain these new in-office diagnostics, I think we'll be able to recognize disease states earlier, be more proactive as more severe states present to us, and have it be a call to action that the clinician really needs to pay closer attention. Much like, it's one thing to check a blood sugar on a diabetic, but if you check your A1C, now you've got a better idea of what the disease state is, and you need to increase your aggressiveness of control.
Yeah, so Versailles is going to be launching point of care diagnostics with IgE to look for ocular allergy, and then lactoferrin, and excited to get my hands on this year. I don't know exactly how that's going to change things at this moment in time, but I think we've alluded to the fact that in the future, we're going to have some specific therapies that the more data we have, the better we can customize our approach to a patient. So I think this is a really great first step. And then now we actually, for the last couple of months, have had the Scout Pro in our clinics from TrueCare Medical. We've had the TearLab system for over a decade out in the market, but now we have a handheld device that allows for even the easier acquisition of the tear film osmolarity. I know, Laura, this is just a huge part of what you're doing in your clinic. Have you had your hands on the Scout Pro yet?
I have not had my hands on a Scout Pro. We're waiting to move to a larger clinic space, and then we'll have actual, ability to incorporate that specific device. So for now, we're still using the old system, and it still works great. But I love the portability and ease of use of this, especially for new staff members that are joining your team.
I was really excited to see cyclosporine being discussed as an anti, kind of a allergy, medication. But we've known that, and I think, Laura, you are one of the, my respected colleagues that I learned a lot about as far as the immunology of ocular surface disease, and to know where cyclosporine actually is effective in the, allergic cascade was really exciting to see that come to us as in Verkasia. Along those same lines, you guys, Rich, I kind of wanted to pick your brain about just sort of, different types of lubricating drops again. There's, again, a plethora of treatment options. These are some of the really latest and greatest, lubricating drops that we have available to us. And the theme now, of course, is that when we've, got these patients that maybe have polypharmacy, other, inflammatory conditions, we want to preserve, preservative-free lubricating drop. What are some of the other things that maybe you look for in these new and really innovative formulations, as to maybe having an added kind of anti-inflammatory effect in addition to the preservative-free features of all of these? And what do you use on what patient?
Yeah, it's a great question. It's a great observation too, because, as we get more and more of these options, it can sometimes feel like a bit of analysis paralysis, right? Like we tell our patients, when you go to the drugstore, there's 5 feet of choices in front of you. Where do you start? I mean, that question can almost be posed to the practitioner as well. Where do we begin? How do we select? And so I've been spoiled a little bit in Canada. We've had hyaluronate-based products in Canada for greater than a decade. So I've worked with hyaluronate a lot, and the addition of disaccharides to the hyaluronate story has been really, really exciting. So, in Canada, we have Thea, who has Thelose Duo, which is very similar to Avizia, containing both the trehalose and the hyaluronate. And so I like the leveraging polysaccharides in general. I really do. I think that it actually has a more than just an anti-stress effect or an anti-inflammatory effect. I think it actually is probably a little bit more specific than that in regulating, aldehyde, for example. We'll get into some of the futures later. But when it comes to tear selection, I look at a couple of factors. I look at, what component or what aspect of the disease is, MGD or evaporative, and what aspect is aqueous. And I use that to choose drops that have different rheological properties, meaning, a drop that has more of a non-Newtonian behavior that goes through shear thinning, for example. So as the eye blinks, the tear will actually thin. It'll lose its viscosity, which is what we want. That's very biomimetic to our tear film. So for patients that are highly evaporative, I want a drop that's going to behave like that, that's going to actually have a longer residence time. But on the contrasting that, for patients that have high inflammation, if I see that perilimbal staining, or if I see SLK, or if their MMP9 is up, then I definitely want to reach for a lubricant that contains a polysaccharide like trehalose, which is why I really like the Thelose and the Thea line specifically for that. So I've kind of gotten away from, look, this is the one lubricant for you, to you're going to need this lubricant for this part of your day and this lubricant for this part of your day, for example. We have multiple drugs that are coming out. We're all thinking, how are we going to use these drugs together? Well, before we even get to the drugs, I think we also have the ability to take a multimodal approach to lubricants, depending on the time of day and depending on how the patient presents.
Awesome.
Non-Newtonian properties of the artificial tears.
Yeah, I'll extrapolate on that a little. So basically, when you exert a force on a solution, so water is Newtonian. Water doesn't change no matter how much pressure you apply to it. But an egg yolk, if you were to whip that egg yolk up, it's going to get thick. Or if you have kids that make the that slime, right? You know, it gets thicker if you compact it, and if you hold it in your hand, it just drips through, right? That's non-Newtonian behavior. So we want non-Newtonian solutions on the eye because the tear film is non-Newtonian in its nature. And there's some drops that are more non-Newtonian that have a steeper thinning curve. So as the blink force is applied, we want that tear, that lubrication, we want that to thin out and not provide resistance to the blink or increasing friction.
And I love seeing these smarter formulations coming out, right? So, and I love the multi-dose preservative-free bottles from an environmental standpoint, and the savings in plastics and landfill. I think that's a real boon as well. So the formulations have improved dramatically. Love the like he said, the mimicry of the normal forces of the precorneal tear film on a blink. And so the closer we can get to that, I think the better off we all are. And there's wonderful options. These are all fabulous products. I love the hyaluronic acid in them as well to prevent desiccating stress on the corneal epithelium. And that, like to your point about the trehalose, what a fabulous molecule for preventing apoptosis and autophagy and all these other really interesting things.
Awesome. Yeah. So it's really exciting to be able to have, really maximize these treatments. Kind of along those same lines, we can all agree, on this panel that cyclosporine has been, long sort of proven to be a very good anti-inflammatory. We'd had, multiple, sort of versions of this. And how important to you guys is kind of not just the main ingredient, but how we get it into the ocular surface. And of course, a good example of that is what we have up right now, where we kind of use this N-cell technology where that hydrophobic core is preserved, trying to kind of get that main ingredient, anti-inflammatory ingredient, through the tear film and into the tissues. So how important is it? Is it sort of cyclosporine that's the most important thing, or is it how we get it into the ocular surface? And can you guys just kind of have an open discussion as to what concentration or way of getting it onto the ocular surface in residence time have you found to be most helpful in your clinics?
I'll take this one. This is so fun and interesting. Cyclosporine is a molecule found in nature, and it does have these awesome immunoregulatory, steroid-sparing properties for really mitigating several phases of chronic inflammation. It also helps to protect goblet cells and increase the concentration of goblet cells. So it's a very important molecule in our toolkit. It's a little tricky to formulate with because it only likes fatty stuff. It does not like water. Sort of like cats, they don't like water. So or Jack Sprat's wife, it likes only fat stuff. So you have this challenge of getting this lipophilic molecule to where it needs to get, where all that inflammatory activity is going on. And that's the beauty of the nanomicellar technology. You're able to put that fat loving molecule in an aqueous solution because you have bubble wrapped it in a system where it's oily in the middle, water on the outside. And that allows it to be in an aqueous solution, but also allows for that better penetration into the corneal tissues where all that inflammatory mischief is going on. Head-to-head study, emulsion formulation versus nanomicellar formulation, you get 3x higher concentration in the ocular tissues. And that is clinically significant for many of our dry eye patients who have previously not experienced enough success with emulsion formulations. Or in the US, we now have problems with generic products that really don't have the same kind of proven bioavailability.
Laura, what's been your experience with generic cyclosporine specifically in the US? Because we've had that now for 8 months.
It's been kind of interesting. So there's four main manufacturers. You can actually still get a trade cyclosporine emulsion or Restasis, but you don't really know what you're going to get when you write that prescription. They could get subbed out for a generic substitute at any time. And we learned our lesson with glaucoma drops, you guys. Like, we know that generic glaucoma drops do not work as well as trade name. At least in the US, the FDA allows equivalency or efficacy to be within 71 to 130% as the trade. And that's a wide range that has clinical performance consequences. So with a trade name product, you know you're getting the percentage that you want. You know the drug delivery system is what you need. And so I will always favor a trade name product.
I completely agree. I'll just make a quick comment here on the Malik Hook had a nice, study looking at the same thing, how these different medications and the particulates that are found in higher concentration, some of these generics. And I routinely have patients that say, I, started this generic eye drop. Now my eyes are stinging more. And, X drop that I was switched from was $40. My generic is $47. Can I please get back to the one?
Really that?
So it's not, sometimes the cost, we think it's always going to be a cost savings, but sometimes it's really not. Have you guys found that at all?
Yeah, definitely. I mean, in Canada, it is a little bit different. The landscape here is different. We've had a few more generics available. But yeah, it does come down to sometimes pointing out those sort of minimal cost differences compared to the difference in performance on eye. When I think about, for example, we're talking about NSAID. When I think about NSAID and I think about the impact that it has on compliance, if the disease gets better with a medicine, compliance is going to be higher. And it brings me back to, thinking about contact lens discomfort and how, we really lean into the most comfortable contact lens because we know that our patients are going to be compliant with it. So to me, it stands to reason to apply that same logic to pharmaceutical selection. If we know, for example, in this case here with Sika and the NSAID, if we know that we're getting better tissue penetration, and I've seen, just clinically speaking, I've seen, increased tolerance to patients that sometimes were previously intolerant to the emulsified formula. I love the fact that I have this option now because we can keep them compliant on a drug that we know that works and have an impact on the disease. So, at a clinical level, great, but from a compliance standpoint, I really enjoy having something like the NSAID technology, and I tend to stray away from generics whenever possible.
All right, so neurostimulation. I think that this is really a really innovative space. I just kind of want to leave it completely open-ended here. How much do you guys use it? How much is it better than our first, kind of experience with this? And what is your patient's reaction been for those patients that have maybe aqueous deficiency, we're throwing the kitchen sink at them, and they're just not getting that therapeutic benefit? How has this been working in you guys' clinics?
Yeah, so in someone that's using artificial tears more than a couple of times a day, I started having that conversation about Tyrvaya. It works immediately, takes a few weeks to see some symptomatic relief. Really have some home runs with Sjogren's patients in this product. It's like nothing else they've ever had before. I can't always predict who's going to respond to it, but autoimmune disease patients, a lot of big wins there. I like it after I've done in-office treatment, whether I've done IPL, thermal pulsation, to kind of keep that lacrimal functional unit working, I think is a nice adjunctive agent. But I also will use it first line in people that are just using teardrops. If they don't have a lot of inflammation on the surface of the eye, maybe this is the first step, and I've had success there as well.
I'll chime in on this. So we had the privilege of being a phase 3 FDA trial site for the iTear device, the external mechanical nasal stimulation device. And I believe they have approval in Health Canada. If not, it's going to be very, very soon.
Coming.
So and you asked the question about how does this compare to our initial experience with the first generation neural stimulation device. I'm talking about the TrueTear nasal electrical stimulation device from Allergan. That all these modalities work, and they all work about the same in general. However, it was just a tough business model. So all those modalities work. We were able to demonstrate delivery of meibum from the terminal ductules under video slit lamp microscopy during external nasal stimulation. I haven't repeated that with the intranasal chemical Tyrvaya, but you can actually see meibum delivery. And how I explain it to my patients is like, listen, the whole production tear apparatus is kind of like an electrical system. And for you, post-surgical, neurotrophic, contact lens overwear, autoimmune disease, whatever it is, the rheostat has been ripped off the wall. Well, we have a backdoor way of stimulating a healthy and complete, physiologically complete tear through activating the nervous system through another pathway.
Yeah, we don't have it in Canada yet, Tyrvaya, and I was a little birdie, and I won't mention anybody's name who might be on this panel or not, but a little birdie gave me a little sample to try, and recently we haven't got it in Canada, but my experience has been very, very positive with it. Personally, I do use it personally. I think where it fits in terms of our patient selection, I think where it fits, Damon, you pointed out, the lacrimal functional unit, keeping that that stimulation happening and inducing it when the rheostat is broken, as Laura has put it, sometimes that electrical system needs a little bit of help. So I actually see this belonging in both the episodic as well as the chronic patient, even the recalcitrant patient. I think it has a role at these sort of three spots, and it depends on convenience, compliance, and also I think the data will bear out in a few years perhaps, but I think when that system breaks down, when the lacrimal functional unit breaks down and we start to blend into neuropathic and neurotrophic issues, I think this may end up being a tool that we use to actually prevent that from happening and keep that lacrimal functional unit engaged.
Richard, I love the way you think. Like, that's just so awesome. So varenicline is Tyrvaya, and it's 0.03%. We were a phase 2b clinical study site for varenicline 0.12, 4x the concentration, dosed TID for stage 1 neurotrophic keratitis. So you are spot on the money, my brother.
Nice.
I completely agree with the notion and the sentiment of basically disuse atrophy. We have a dysfunction in that communication system, and keeping it going is so important.
Yep.
So this is going to be a super fun slide here.
Who's this fun lady?
I don't know.
Yeah, who's that? So IPL, using these different, application of light energy, polychromatic, light energy, and Laura, what is your, I want to understand what else is going on with IPL. We know from our dermatology colleagues, this is kind of where it was born, that we have some, decrease in telangiectatic blood vessels, and, sort of a bunch of other, proposed mechanisms of photobiomodulation and meibomian gland kind of stimulating meibomian gland production, and sort of antibacterial. What else sort of is going on to really improve eyelid inflammation and get these glands functioning again, as far as the mechanism of action?
Oh my gosh, thank you. I love this topic. This is my favorite topic. There's actually a Demodex killing effect of IPL as well. That's been well established in the dermatology literature, but we're also able to show Demodex death by video on a glass slide ablated from the eyelashes of a patient. So you can't use IPL on the lashes. So we still need alternative means for addressing Demodex collarettes on the lash base inside the meibomian gland. But I can sure get control of this whole region with it, right? So you get an antibacterial effect, anti-Demodex effect. You improve the meibom biochemistry through enzyme and biochemical changes through photobiomodulation. You control the inflammatory load. Acute inflammatory cells are exquisitely sensitive to the IPL energy, so much so that when you treat chalasia with it, patients will say, oh my gosh, where'd the soreness go immediately after the procedure? And you'll see a reduction in swelling immediately. Then you've got the stasis, altered melting temperature improvements, and the obstruction. But I wanted to share something hot off the press. We just closed out our IRB approved study looking at IPL for treating chalasia. And we had 91% of our patients, this is a multi-center site, 91% of our patients had an 80% or total resolution of their chalasia in 2 treatments, really conservative settings, placed 2 weeks apart. We identified a couple risk factors for incomplete resolution or needing more than 2 treatments, and that was the presence of Demodex. So we still need a tool to address that load specifically in the lash follicle, in the meibomian gland themselves. But that, floppy eyelid syndrome, sleeping position changes, allergic conjunctivitis, and proximity to the lash line, those were the main risk factors. But otherwise, it worked so well in the clinical research study.
I don't know if you guys could see me leaning in when Laura said that she's got something juicy, but I really leaned in. I wanted to hear that. Fantastic. That's such a great, I love to hear that. Cause I mean, clinically, I observed the exact same thing. And it's nice to see that that's going to be coming out, formally. Laura, I'm curious to your thoughts, actually the whole panel really. to your thoughts on, with all these different technologies for IPL, and we have RF as well. I am kind of curious, and maybe this will come up a little bit later too, the difference between sort of different technologies versus different techniques. I think technique and technology, I think, are kind of getting blurred. And in my opinion, I think that technique really is something that can be differentiated more so than with the technology. I mean, every sort of system out there is going to make the biggest claim that, yes, we are the best, we have the best control or the best system. But I think technique really is an important feature there. And investing in learning these protocols and adapting these protocols and understanding dermatology to the degree necessary, I think that's really, really critical to being a successful, dry eye specialist and using technologies like this.
I agree. I'll be totally fair. I've only ever driven the M22 and the Optilight, so I can't speak to performance of other platforms, but we're really bullish on technique. Like we got it strict, and there's protocol and it's followed. And I think that's why we get the amazing outcomes that we do.
Awesome. Along those same lines, there's another slide here that's kind of, intense regulated, IPL. And so I want to kind of ask the question, IPL versus IRPL, do you guys see a difference? I mean, was one of them mostly kind of, again, brought to us by our dermatology colleagues, and one was just kind of more, kind of put together with the intent to treat meibomian gland dysfunction? Is that really one of the main differences, or is there some other kind of technology differences there that between sort of conventional IPL and IRPL? Rich, I was just wondering what your thoughts on that, if you can comment on that a little bit.
Yeah, I think so. The IRPL, it comes out of France, the EI system, and it's available in Canada as well. I think that the main differences in terms of performance, I don't know that they've been compared head to head necessarily. They have. Okay. Maybe I'll defer to Laura for this one.
No, keep going. You're doing great.
Yeah, but in my experience, I do know that as a system, it is specific for MGD, right? It's been tested and tried for MGD, not necessarily the EI system is not necessarily for derm. I think with I'll speak to the Lumina system. That's the system that I drive. It does offer more versatility and allows us to be, as clinicians, a little bit more. We can customize these treatment options for the patients. The settings are a little bit more adjustable. I can adjust affluence. I can adjust the intervals between settings. So I feel as though I have more control with the Lumina system. But the IRPL, again, the data that came out, and I believe it was included in the TFOS Dues 2 as well. It was published in there as one of the options. I think it's comparable. I also understand there's different business models too, right? The EI system also has more of a consumable model. And that can sometimes be a bit challenging. Laura, what were you gonna add to that?
Yeah, so there was a head-to-head study out of China 2 years ago comparing IPL with ERPL, and that it showed that while both systems worked, there was superior effects with IPL. But to your point about business models and price points and clinician access to these tools, one advantage of ERPL is that you can treat the 5 and the 6, the Fitzpatrick 5s and 6 with it. So to me, that suggests that it may not be as powerful, but to have that range where you can treat richer skin tones, that does have an appeal to it.
So some other things we're looking at here, tear care, sustained eye squared, low-level light therapy, the Equinox from Marco. I have all of these technologies in my office. I've had the Marco unit for about 6 months. I was kind of skeptical on low-level light therapy in general, but just treating a few patients, it's the real deal. It really helps patients. It helps get a really good meibomian gland therapeutic expression after we do the red mask. And I've used that in cases where it's not quite as advanced and maybe there's not as much rosacea, where I would go towards an IPL. It's actually at one of my satellite offices, is a little bit lower price point. So I found that a nice niche for that in my practice. I've had good success. And then, tear care has kind of been my workhorse lately for meibomian gland obstruction removal, and just really works well, can customize treatment. Ilux squared, I kind of position as that mild to moderate level of obstruction. We use that quite a bit in our pre-op cataract clinic.
And now I just want to kind of throw one more thing out there. let's, kind of like, higher technology, IOLs? Are you guys mixing and matching with any of these amazing technologies?
Yeah, I mean, I'll jump in. I think the pairing of IPL and low level light, I think that actually goes a long way. I think that photobiomodulatory effect that both exert in different ways end up actually become synergistic. So I actually like the pairing of the light technologies. I also like the pairing of light with the thermal technologies as well. So we don't have it up here, but LipiFlow again, pairing that with low level light and pairing that with IPL, it's really for those waxy plugs, pairing that IPL with LipiFlow or with a thermal option really makes a lot of sense. And the one thing I think is important just for the audience as well, with the ever changing, the ever emerging options that are becoming more and more available, much like in the drug space, these technologies, it becomes a little bit, daunting to say, oh, what should I have in my practice? I think what I would say, and those of you that might disagree with this, by all means speak up, but I do think that if we're taking a procedure-based approach to treating MGD, I think regardless of the technology, I think you're already doing a service to your patient, right? So whether you have IPL, whether you have, a thermal option, I think that treating MGD procedurally and interventionally, I think that we're already a step ahead. So making that first selection, I think you need to look at your demographics, Fitzpatrick skin type, but having multiple modes, if you have the ability to do that, to invest in that, they certainly are synergistic and helpful.
I'm so glad you pointed out that patient demographic piece of it. There was a paper, Carl Stonecipher was the lead author, and he was able to show improvements in pediatric chalasia using low-level light therapy technology. And so if you're a heavy pediatric clinic and you've got kiddos with recurrent chalasia and styes, it's a really comfortable, easy thing for them to do, much easier than IPL for children.
Awesome. One more, really cool. So instead of, using bursts of light, another technology out there is actually using high frequency or kind of radio frequency electrical stimuli. So another technology to basically warm up the lids, get up to that therapeutic temperature. Radio frequency is another technology that's been out there for quite some time. I just want to kind of have an open-ended question. Do any of you kind of have any sort of hands-on experience with this? And where do you see this, fitting into the things that we just talked about? Might it work synergistically? Again, it's another one of those technologies that really wasn't developed with meibomian gland dysfunction in mind. It was mainly developed for wrinkles, but lo and behold, you put it on the lid long enough, you get that good warming of the lids, and that also helps with meibomian gland function. So how do you kind of position this, and what are your general thoughts about this technology compared to some of the others?
I'll jump in. I've been using radiofrequency we had it for about 3 years in Canada. I know Edward Jacoma has done a ton of work on this. He's a wonderful resource in this area. So if anybody has access to Ed, he's a great guy to chat with about this. I certainly think it's synergistic. And you mentioned the collagen rejuvenation aspect of it. Yeah, there's certainly an aesthetic impact that it has, but above and beyond that, so it elicits an effect at the gland level. But actually, I think Laura, you and I were probably talking about it. We probably talked about this a ton, but that sort of gentle tightening of the skin, the periocular skin, you can sometimes actually get better lid apposition, which also helps to, kind of keep that tear on the eye. So I think there's also a very slight, subtle mechanical effect, which helps to keep that tear reservoir on the eye. So in addition to that MGD effect, I think that we're also eliciting a mechanical effect, which is a really nice addition to some of the other tools that we have.
I love that. We have a radio frequency as well, and I really like it for my patients with significant floppy eyelid syndrome. I think we underestimate the power of the mechanics involved in dry eye disease, whether it's excess friction from too much blinking contributing to superior limbic keratoconjunctivitis. But in the case of I'll use Botox for that, just the tiniest little bit. I'll teach you about that later if you like. But in the case of floppy eyelid syndrome associated dry eye, you get a twofer out of it. You mobilize the meibum and you tighten the lids. And that's really great if a person's not ready for surgery. And when you repair floppy eyelids surgically, it's never great. Like you really want to try to avoid that if you can. The outcomes are meh. So if you can treat it with a less invasive modality, that's my preference. And I won't apologize for the wrinkle improvement.
We got a $10 question for you then. On those patients that you've treated, you guys, do you actually see, like if there's a lot of eyelid imbrication from the floppy eyelid syndrome patients, do you see an improvement in their overall blink after RF?
Improvement in their mechanics of their blink and the wet and spread of the tear film. Have you observed the same, Rich?
Yeah, absolutely. Yeah, I've definitely noticed an improvement in retention and a physical difference. I've even observed, because of that, I think I've even also observed an improvement in chalasis as well. And I'm not saying it has a direct impact, and I don't want to, put my foot in over that line, but I would posit that there's likely a slight effect.
Oh my gosh, that's super cool. We're also playing around a little bit with plasma pen technology.
Yeah.
There's a new Visa plasma pen technology that we're, pioneering some protocols for addressing those minimally invasively in the clinic.
Finally, preservative-free latanoprost. Rich, I know you probably had this for a few years in Canada. What's your experience? This is going to be launched IUZA by Thea here in the next few months. What should we be looking for in this product?
Yeah, so in Canada, it's called Monoprost by Thea, and same product. I think Daryl White just published something as well, and he, one of the quotes that he had is he's committed. One of his New Year's resolution is committing to, reducing the burden on his glaucoma patients on their ocular surface, and so this is a perfect vehicle to achieve that. Latanoprost has been a stalwart in glaucoma care for as long as I can remember. So having this non-preserved option, keeping our patients glaucoma controlled while being precious to their surface, I think, having this option really is a great segue into even just having that conversation. I don't know that a lot of glaucoma docs historically have spent a lot of time saying, look, I'm going to do everything I can to preserve your ocular surface. And by the way, I'm going to treat your glaucoma. It's usually the inverse. Right? We're going to keep your pressure down. And look, sorry for giving you dry eye. Here's somebody else that can take care of it. Well, now we have this option where we can also be mindful of your surface, remove that preservative, but still have the efficacy of latanoprost. So it's been well accepted here in Canada, and I know in Europe it's been quite popular as well.
I love it. That's so great. I love any strategy that reduces the preservative load on the ocular surface, right? I mean, preservatives are important, but if you can reduce the load and deliver it safely, you absolutely should do that. Like, why are we punishing the cornea for the sins of the trabecular meshwork, right? It's like, we're kicking the wrong dog here.
Yeah.
All right. Well, as advertised, the hour is flying by. So we will go into a couple quick hitters on our evolving treatment algorithms. I have not two cases, but just kind of two clinical examples of things that I see every day in my clinic, and thinking about how we manage these patients now that we are doing a diagnostic meibomian gland expression. We've got this really thick, turbid, paste-like meibum coming out. Laura, when you look at that, without knowing a whole lot about their case history and comorbidities, what are some of the things that you are looking at as possible therapeutic options for a patient that looks as bad as this particular patient does?
Current or future or all the above?
Right now. So I know
Right now.
maybe 5-10 years ago, we were doing something totally different than you're doing in 2023. How are you attacking those meibomian glands today?
Yes. So this situation looks like it needs a good cleanup. So we like to use the Zocular kits, the Zest kits. I love the manual feedback. Like, as we're doing the procedure, it's like sandy gritty. And just like getting your teeth cleaned, you know that they're done scraping away that section of biofilm when it's smooth. So you get that same tactile feedback. Plus, to what we were talking earlier about helpful polysaccharides, this has a polysaccharide in the gel that is anti-inflammatory. So step number one, you got to clean it up, right? That's the first thing I would do. And then I would look to see if there's a rosacea component. I'm a little suspicious there's Demodex mites. So
Yeah.
I'm going to teach about home lid hygiene. I'm going to have them replace their makeup on a more regular basis. Demodex will live for 5 days in mascara. Ooh, nasty. So I would start there and then treat whatever I can. If their MMP9 is elevated, their osmolarity is elevated, I'm going after it with immunomodulators. Depending on how dry and how much keratitis is, I might add a neurostimulation device. And then probably IPL. And if I don't see significant improvement in that kind of mybome, then I missed something, right? So what did I miss? One thing I would want to find out in this patient, like there's almost a chicken fat consistency to this mybome, right? Sometimes it's like silly string, which I still don't understand why that happens. But in this case, it's like gooey fat, chicken fat, right? Ask your patient about dandruff. That is an indicator of seborrheic dermatitis. It's a fungal organism that infects the scalp, the brows, and the lashes. It makes the person hyper sebaceous, but it's the wrong kind of lipid, and that needs to be treated, and it's affordable to treat with topical ketoconazole treatments. That was a long answer, sorry.
No, that's great. Rich, I know you have, you presented this slide on interventional MGD framework. How would you look at that patient clinical signs there and kind of walk us through your MGD treatment algorithm?
Yeah, so this is 4 years old, so there's definitely new additions that have come onto this. I started doing introductal probing after chatting with Steve Maskin many years ago, and he kind of put me onto it and really opened my eyes to, reestablishing the patency of the ductal framework. So this was sort of something that I talked about with my students. We developed just a decision tree really, and kind of understanding when it applies and when it doesn't, also how to integrate a multimodal approach to treating it. So one of the key markers for periductal fibrosis or scarring within the gland is tenderness of the lid on palpation. And so that for me is usually the first thing that I look at. When I'm palpating, does the patient wince? Do they jump back? If they do, then the next question is there ocular rosacea there? And should there be ocular rosacea, then I want to tamp that down with a procedure like IPL, reduce that inflammation first before I consider doing intraductal probing. If there isn't rosacea, and there's lid tenderness, then intraductal probing can be proceeded with because I'm not too concerned at this point that there's going to be a high inflammatory response. And then if need be, we can tack on a thermal option like LipiFlow. In the absence of lid tenderness, it's not to say that there isn't periductal fibrosis, but there is an obvious periductal fibrosis. So in that case, we go down the same pathway. If rosacea is present, again, we want to treat that inflammation first with IPL, and then if need be, follow with LipiFlow, or vice versa in the absence of rosacea. In any of these situations here, multimodal approaches can still be added on. So if you have ILX squared, if you have tear care, you can kind of plug and play these into this framework. So it works really, really well. It served us well. And going back to that last patient and looking at it in the context of this, the only other thing that I'm not mentioning here is non-procedural. It's non-therapeutic. It's actually something that we do every day. It's what's in our gut, and looking at gut dysbiosis and considering our dietary contributors as well. When I see that paste that was coming out of that last patient, that's one of the first things that I think about is, what's their day in, day out diet like? Are they, Coke and fries and 3 Big Macs to go, or are they having a Mediterranean salad? And, Mila Iosifova, she does some great work from a nutritional standpoint. So I really do think that that's a strong piece as well outside of the procedures.
I couldn't agree more with that. And then of course, nutraceutical supplementation, all those other strategies. And I definitely would add on thermal expression. We have the ILX system, so I would add that on as well if it was appropriate and as needed. I definitely agree with you on the introductory probing. It really helps some patients. I don't lead with it because I like to try to allow Mother Nature to nudge her a little bit, see if we can get those patent again. But some people really do benefit from it.
Yeah.
I'll jump in just really quick on the introductory, probing, meibomial gland probing. I find it to be helpful when I'm doing the expression, kind of going across, and if there's 1 or 2 glands, there's just nothing coming out of, I kind of pay a little bit more attention to those glands and look at the lid anatomy in that area. If there's some notching or some fibrosis, usually I'll use the 1 millimeter probe initially and then express again. And oftentimes I get some oil to finally come out of those glands, where initially when I was expressing, there was just nothing coming out. So definitely some selective, probing has been super helpful for my patients too. Yeah. And Steve Maskins is such a nice guy. I really enjoy.
Smart doc.
He's
Smart
super-
doc, very
Mhm.
generous with his sharing.
Yes.
I have one more slide for our
Ooh.
patients that, how have we changed our treatment algorithm? Say this patient came in as a new patient referral, and maybe they'd try some artificial tears, maybe even some topical steroids or topical immunomodulators. Rich, what you look at this cornea in terms of making an accurate diagnosis, next therapeutic steps, how does that algorithm look in your clinic today?
Yeah, so if they've been non-responsive, a patient like this is non-responsive, the first thing I see is that sort of central band. I mean, this looks like it's likely going to turn into filamentary keratitis if it hasn't already. There might be already a neurotrophic component here, depending on what the patient's symptoms are. So that's my initial concern. In addition to, I'm not sure what lubricants they've tried before, but I would, again, rheologically speaking, I would reach for something that's a little bit thicker, a little bit more viscous. So again, in Canada, I would reach for something like an eye drop MGD or an Evolve. In the United States, I'm sure you guys have your thicker hyaluronate agents so that we have longer residence time. But these are cases where I wouldn't hesitate to reach for an amniotic membrane. I might even consider blood-derived products here. There's a big notch in the bottom there, so I know that this patient has severe MGD. They may in fact have periductal fibrosis, so reestablishing that gland patency with probing might be indicated. Laura's going to love the juiciness of all the makeup that's on this lid, which I guarantee is contributing here. So for sure, we want to clean it up. And I would echo what you said earlier, Laura, which is I love the Zocular product. I think that it's great as an anti-inflammatory, but it also is a nice analgesic as well. There's sort of an immediate nice feeling that the patient has on the eye. And I've actually had some patients where we just use the ZocuShield, cases like this, where there's sort of these mild neurotrophic tendencies, and we see that surface clear up with just ZocuShield. So I would take a very surface approach in this case here, and I'm leaning towards neurotrophic as being a component here.
Nice. I agree. I totally agree with you. And given I want to know what this person's Lisman green staining pattern is like. If you see significant staining on the bulbar conjunctiva, my index of suspicion for autoimmune disease just went up quite a bit. So I would also run Sjogren's biomarkers.
All right, home stretch here. Ahmad, you want to take us through some of the rapid onset treatments on the horizon?
Awesome. Yeah. So as we're talking about how do we get these molecules, which are we kind of next level treatments, and what are the best treatments as far as ocular residence time. Novo 3 is a novel drop that we'll hopefully have at our hands very soon. And what I love about this is that the kind of the clinical data that was going, kind of looking into this really looked at, the contrast sensitivity and, sort of vision, and how that affects the patient. So this molecule, because it has a low surface tension, can really spread out, and not cause a lot of disturbance to the tear film. And so this is another one of those, preservative-free, drops. But the other exciting thing about it is actually being targeted for patients for improving meibomian gland dysfunction. So that's one of the things that I think, it's really a novel drop that we'll have hopefully very soon. And it's specific for patients with the obstructive component as well. So anything else you guys kind of gets you guys excited about this drop?
It feels like a cashmere sweater when you put it on the eye. It's just so nice. It's water-free, it's preservative-free, low volume, really seems to reduce friction, helps to make the tear film more uniformly spread, which I think has benefits for our irregular tear distribution patients, conjunctival chalasis, little pingueculae, things where there's uneven tear distribution or complaints of friction. I think it's a great adjunct for that. The clinical, we were a phase 3 study site for these guys, and all the patients had to have MGD. So they only studied MGD patients, and they were still able to show in as little as 15 days improvements in corneal staining. That was their secondary endpoint. They met their primary endpoint, which is statistical improvements in staining at day 56. So there's tremendous potential for this. Imagine like stabilizing the evaporative load in your dry patient while you're working on why that happened in the first place. So I think it's going to have some really exciting, and we'll have to share best practices of like, well, how are you using it? What's really working in your patient demographic? I think we're going to learn a lot together as we bring on this really unique new category strategy to our patients.
Yeah, and I think, you mentioned it well, it's almost like having scaffolding, right? You have scaffolding as you rebuild the foundation. It's exciting. And the rapid onset is exciting as well.
Awesome. All right, so this is another one. I mean, I've put this in my chart so many times over the last year and a half. Consider TP03 when ready. Consider this when ready. So, there's so many patients I want to, just, have start using this drop. Everyone on this panel knows this very well. Oh my gosh, Laura, you have a little something on your.
That's a big, I know, right?
All right, I'll just let you guys kind of take over. I mean, how many of these patients do you think that you see in your clinics? How much is this going to be actually a part of your clinic? And what do you think about this data overall?
Same experience as you, Ahmad. This is so when you actually go looking for the presence of color, it's just have your patient look down. That's when you can really see them. They're present about 60% of the time, a little higher in certain demographics than others, but it's a significant problem that we previously haven't had a direct killing method approach. Like we can reduce the load with our deep clean or daily hygiene, IPL around the area. Again, I can't get on the lash because I'll lose the lash. We haven't had a direct strategy like this before, so it actually kills them. And I'll save a house spider all day long, but not this 8-legged pest, right? Because this guy contributes to meibomian gland dysfunction, ocular surface inflammation, lid itching. I think this is going to be a game changer for a lot of our MGD patients.
Yeah, I agree. And I think you nailed it on the head there is identification, right? I always tell my students, when you start looking at the eye, look at the eye closed, right? That's your slit lamp exam should start there. If we look for it, I think we're actually going to find it in a lot higher numbers than we're already seeing it. So I love that this option is coming to market. I'm really, really excited for it.
I wanted to share a little something I'll be presenting tomorrow at conference. In the course of the clinical research associated with this, I think I came across a new clinical sign. I want to share it with you because some patients are really good with their lid hygiene. In the study, they had to stop their hygiene for 2 weeks. They could get nice and crusty. But some patients are really, really good at their lid hygiene, and they may still have a significant Demodex load. And if you don't have the time to swirl, epilate, and look under a microscope, take your slit lamp, turn your sidearm at 45 degrees, put the diffuser light up. I use the iFiscient system, Firefly system. Slowly scan from the right eye across the nose as you move towards the left. I call it the Periman alpenglow sign. As you cross the nasal bridge, that first bit of light will highlight the vellus hairs of the skin, but the coarse, thicker ones are collarettes. So I plucked a bunch of those in serial patients, and sure enough, rip-roaring load of Demodex mites in the skin. So I think, and then that's where your IPL can help you, and your skincare can help you, and your topical ivermectins can help you. So I think we really need to think of it as a local, regional problem. But now we've got something targeted specific for the lids. I'm so excited.
So, this reactive aldehyde, species and kind of inhibiting that. I mean, it's just one of these novel markers that we know is linked with inflammation, and specifically in some of these patients we've been talking about before, like that awesome slide that Damon showed with really a lot of corneal staining, where the first thought you have is, what else is going on here? There must be some other autoimmune process here. And so what are you guys excited about here? I mean, I think, for me, there's just some patients that never really look nice and quiet, even though you're throwing the kitchen sink at them with some of your, primary, tools. What kind of patient do you anticipate using this on, and where do you see it sort of being most effective?
I think this is a really exciting approach to inflammation. This is very, very, very far upstream. And I think of RASP inhibition as preventing that first domino from falling. And all those downstream events from a domino fall. This stops the first one from falling. It's that far upstream. And in this molecule in the clinical trials, they were able to show improvements in Schirmer's ocular redness. That's a big deal for so many of our patients, right? They're red eye, dry eye patients. But here's what's really remarkable. Look at the statistically significant improvements in all of these visual analog score metrics. you've got itching, burning, stinging, gritty, discomfort, dryness, highly statistically significant improvements with this medication. So I'm very excited to add this to my toolkit.
It's my understanding, and maybe Laura, you have some insight, or Rich, is that I mean, this is going to act as an anti-inflammatory, but it also starts working symptomatically within 5 or 10 minutes of application. Do we have a grasp as to why that is happening based on the MOA or just this molecule?
Probably has something to do with the rapid disappearance of the aldehyde species. So this is a sink, and it soaks up all of those modulators, and they're constantly activating the corneal nociceptors. So to go from like, dirty, let's say smoky honky tonk to pristine mountain air like that, of course you're going to be feeling better on the ocular surface. So I think
you're draining the dirty bathtub, right? And it just quickly goes away. All of that toxic rasp gone, and then it's wow, yeah.
And now the corneal nerves are like, oh, I feel better, right? So I think there's some exciting things to explore there.
Yeah, so we may have this, later this year. All of these things we've been talking about have been submitted for FDA approval, so pretty exciting stuff here.
Great year for dry eye patients.
All right, we'll kind of go back to where we started. So again, cyclosporine, 0.01%. And again, kind of in a novel, kind of water-free, formulation. So again, kind of the awesome thing about our tear film is it's a nice barrier. The complicated thing about our tear film is we're trying to get medicine onto the surface of the eye. It's a pretty efficient barrier. But again, just kind of another, novel formulation of cyclosporine, 0.1%, the xylitol drop. I mean, another, how do you, kind of position this in your clinics? And how does that relate to some of the other formulations that we already have, as we talked about the kind of mycel formulation earlier?
I think.
Go ahead.
Sorry.
Go ahead. No, please.
I think, like you said, we're going back to basics. We're starting back at we're going back to where we started. And I think it points to the strength of cyclosporine as a foundational agent to manage, the crazy cascade that can occur. And having more options is wonderful. Having a 0.09, having a 0.1, I think what we're going to start to now realize or figure out is, where do these different concentrations belong? And is it a linear response? Is it a compounding response? I think we still have to figure that out. But again, I like the idea that we're having, increasing compliance because of decreased adverse reactions. I mean, that's what I'm loving about all these new formulations, is that they're becoming far more tolerable than some of the emulsified formula, and quite novel too. So we're getting more drug to the surface. And again, cyclosporine has kind of paid its dues, I think. I think we all know what it does. It's nice to have different versions of it.
Yeah, as you kind of wrap up here, last slide, and maybe Rich and Laura, we've got these different formulations that maybe they're not going to be out in 2023. They're in phase 2, or they'll, but not quite at the finish line yet. Which of these molecules do you look at, Laura, as like, wow, I can't wait for this to potentially be available for my OSD patients?
All of them, like they all have utility, right? So for example, the AR11 or 15512, that is a TRPM8 agonist. So it activates the cooling receptors in your cornea to directly stimulate tear production. And it has a central pain relieving projection pathway. So, and pain is a significant component to many of our dry eye patients. So immediate tear production, relieve some pain, love it, right? So, and then the hyperkeratinization problem, like how do we solubilize that net that's blocking the terminal ductual? So that's why I'm excited about the selenium disulfide product. Their clinical data looks amazing too. The ability to deal with non-healing corneal defects. I mean, this is really cool. The KPI 012 is bone marrow derived mesenchymal cell exosomes. Whoa. So it's all the intracellular machinery that helps with cell survivability. That's hard to say fast. And wound healing effects. So I'm really excited about all of these things.
Yeah, and it doesn't hurt to have another corticosteroid in our back pocket as well to reach for. That's on indication. So yeah, I'm equally excited. The tryptase receptor story is something that I've been talking about for a while. So I'm really excited about Erie's launch and certainly the anticharalytic effects of the Azura. So, but again, to speak to where we started with, it's just such an exciting time. Like this is going to be a great year. 2023 is an exciting year for dry eye. And having more agents just means that we need to be far more attuned to the surface and look for, the linchpin that ties the treatment to the disease. I think we're able to be a little bit more specific now.
What a fantastic session. Very deep dive into innovations available now, innovations that should be hopefully available in 2023 in the US and beyond. So thank you so much to my co-host, Ahmad Fahmy. Thank you to our panelists, Laura Periman, Raj Maharaj. I hope you enjoy Eyes on Dry Eye 2023, and we hope to see you again real soon.